மூட்டை இது ஸ்லைட் மூவ் பண்ணுறது. மீட்டிங் ஜாயின் பண்ணுறேன்.
Very good morning. I request our beloved Dean to occupy the dais and respected Vice Principal and the guest speaker today, Dr. Selva Sitaraman, please occupy the dais. Friends, actually, Transplant, that is Transplant Authority Tamil Nadu, actually we have decided to conduct a series of update lectures on various aspects of transplantation. So this is the second edition of the update series. We had a couple of months ago, there was a guest speaker from the head of the Department of Transplant Surgery, PJ Chandigarh. He delivered a talk, and today is the second edition of the update series. And today's talk is going to be very, very special in the sense that it deals with a very exciting aspect of transplantation, namely the hand transplantation. And I profusely thank our Dean for accepting to preside over the ceremony, and I welcome heartily our Dean and the Vice Principal, the distinguished colleagues of mine, senior colleagues and junior colleagues, and the HOD and the Faculty of Plastic Surgery, Vascular Surgery, Emergency Medicine, General Surgery, and my colleagues in Transplant. A warm welcome to you all. I'm so happy the senior professionals of plastic surgery from our institution as well as the other institutions are there. Why it occurred to me to arrange for a talk on hand transplant? Organ transplantation itself is a marvel of modern medicine. We are all very very much aware about the simple transplants like kidney transplant, which has been happening over the past 3.5 decades here. There's not much of excitement about the kidney transplant now because we are going to reach 2,000 number here. And the liver transplant, with the efforts of our dean, and already we have performed about 12 transplants in liver, and the heart and lung and all other things. We are aware of it. But as hand transplant, still it is in an infancy. So I learned that it is a very, very laborious and very labor intensive, highly complex surgery, because it is not so simple, because there is going to be the demand for anastomosis of multiple plastic surgery, plastic cosmetic surgery, Gleneagles Global Hospital. He is also the director of Silva Plastic Surgery Clinic, Chennai, and is the honorary consultant, Cancer Reconstruction and Microvascular Surgery, ICF Hospital, Southern Railways. He is an associate professor, Department of Academics and Research, Global Health City for DNB program and postdoctoral fellowship program. And he is also a faculty microsurgery trainer, Ethicon Institute for Surgical Education. He has performed quite a few hand transplants, and most of his accomplishments have attracted very wide attraction. He has even received, he is the recipient of honors from the former Vice President of India for his excellence in the hand transplant. And also, other area of his interest is the mandible reconstruction, particularly for the cancer-afflicted patients. Majority of his professional work is reconstruction for cancer patients. He has been trained in the largest cancer institute in India. He has been in the field of cancer reconstruction surgery for more than a decade, and he has also received briefly training in Taiwan and Japan, one of the best centers. And he is an expert in micro and super micro lymphatic surgery, which is important for reconstruction in lymphedema patients and so on. So I'm very happy to invite, and I profusely thank for accepting our invitation. I request our Dean to say a few words of felicitation and Vice Principal to say a few words of felicitation, and then
A very good morning to one and all present here. It's always happy to be amidst the CME where we learn new things, of which this hand transplant is a very new concept. But I was in immunology department for 6 years where we did HLA typing, cross matching and so on. So at that time hand transplant was explored at during my house surgeon period, I did it as an elective where hand reconstructive surgeries was done. It was so amazing to see all of them work day and night throughout. Any type of hand injuries would come there, and the department was doing a wonderful job. But then in that CME they had said the hand transplant, why it is not taken up so much, as not as other organs was, because those who have had their hands transplanted, they could not accept that hand because it is somebody else's hand, and when they use it for their body cleaning or anything, they're not liking it to be as a part of their body. Like, so the intricacies of the surgery is also so very minute, as Sir had said, and so let us look forward as to what can be done. Like from our speaker we can hear. Thank you.
Good morning to one and all present here. Respected Member Secretary Professor N.G.K. sir, HOD of Plastic Surgery Professor Sukumar, Dr. Selva Kumar, today's guest speaker, Dr. Selva Sitaraman, Vice Principal Dr. Kavita, postgraduates and my dear students. Very good morning to one and all. It gives me immense pleasure to preside over this organ transplant update series. I wanted to thank Professor N.G.K. sir for having this excellent topic in MMC, especially for the benefit of our postgraduates and for the UG students. Organ transplants and organ donation sensitization program has been successful in our state. That is one of the reasons for consecutive 4 or 5 years we are standing first in the nation. That is because of the, and after N.G.K. sir took over as member secretary, you would have seen a lot of reforms and lot of sensitization program. Almost in a day, one organ donation is happening across the state. Till day, I think they would have crossed more than 150. 151. 150. From January to till day, they have crossed 150. And the Rajiv Gandhi Government General Hospital alone contributed 22 in 143. That I wanted to, wholeheartedly I wanted to thank Dr. Gomadi and her team, Dr. Jayanti and others, and also neurosurgery department. So this sensitization is very, very important, because once the public accept, then only the program can take off. Almost all the organs, liver transplant is happening in GH, heart transplant is happening, cornea replacement, kidney transplant, almost 1,600 kidney transplant has been taken place in GH alone. Now, in continuation of that, hand transplant is another important thing. When I had a chat with the guest speaker, he was telling that in the whole world, 300 hand transplant has been taken place. Out of which, 69 has happened only in India. The major contribution in the world is India. So in Tamil Nadu, only 4 successful hand transplant has been done, I believe. Hand surgery, usually the center of excellence is Stanley Medical College. Well, when I was doing my undergraduation, Professor R. Vengadasamy was heading the department, he was doing it. I used to see the students and overseas students also, they used to come for the observership in Stanley Medical College. Our guest speaker also actually he studied in Stanley, and he did his MCH in Stanley only. So definitely, hand transplant. When I went through in Google, they say it takes 24 hours to complete the surgery. Now reconnection, blood vessel reconnection, skin grafting, bone, all those things. So once, if it happens in government setup, government institution, definitely it will be a boon to the patients, poor needy patients will be benefited. I think this we have to take it further forward. With that idea only, Professor N.G. Kesar has organized this transplant update series, and he has invited the eminent and apt person for this talk. I really wanted to thank N.G. Kesar and her and his team is doing an excellent work. So Transplant Authority, Transplant team is 24/7. They are all working, and when there is an alert, immediately I'm seeing the messages and all, and the thorough screening and all those things is happening. I think continue your good work, and I wish this program a grand success. And once again, I wanted to thank Professor N.G. Kesar and his team for giving me this opportunity to address to the gathering. Thank you.
I take this opportunity to highlight the contribution of MMC and RGGH towards the noble program of organ transplantation of Tamil Nadu. First and foremost is that the honor walk, which has been initiated at the behest of our beloved Dean. Honor walk, you are all aware, we have been doing for every donor. To pay the tributes for the noble sacrifice of the departed person, as well as to pay homage to the relatives who have taken the right decision in the gloomy hour of their lives. The mortal remains of the deceased donor will be taken in a motorized vehicle, and a huge gathering standing on either side and paying tributes. That has really, actually, when it was initiated by our Dean, actually the sole purpose was to pay appropriate tributes for the sacrifice. But it had so many corollary benefits. We never knew that it is going to take the program in a totally different direction. It has attracted very wider attention, and thanks to the government of Tamil Nadu, the first of its kind, a GO has been issued. After the mortal remains are taken to the residents, on behalf of the government of Tamil Nadu, a district collector or an equivalent rank official will pay a personal visit to the residents of the deceased donor, and on behalf of the state, the honors are accorded. And this is the first of its kind, and many other states have started following this. This is number one. Number two, 1.5 years ago, after a period of lull in the deceased donor transplant because of COVID and post-COVID problems, Dean sir actually called for a meeting one day. It happened in the old MMC Dean's office. Still I have the minutes of that meeting. How to invigorate, how to galvanize this program. It was a brainstorming session for about 1.5 hours. He called all the department heads concerned. He identified Professor Gomati as a nodal point, and he formed a core team, a small core team, and then the expanded specialist team. On that day itself, a WhatsApp group was created, and rest is history. And another highlight, which many other institutions don't have, is creation of a separate, exclusive ward, a small ward with 2 beds, with all the facilities, complete facilities for maintenance of the deceased donor. Because you all know, the maintenance of the deceased donor is both art and science. Lot of imponderables, lot of unexpected things will develop. So if you treat the deceased donor as yet another patient on ventilator, most of the times we fail. There are special challenges, unique challenges. Thanks to the team, the core team headed by Dr. Gomati and other members, they have protocolized every component of management of the deceased donor. That is why our success rate of maintaining the deceased donor is very good, in fact. That is very important. Then, subsequently, once the Directorate of Medical Education came to know about such initiatives, the government of Tamil Nadu wanted to replicate all these newer strategies in every medical college. So, batch after batch, faculties of all other medical colleges are sent to RGGH. They undergo a structured reorientation program, which is lasting for 2.5 days. So far, 18 medical colleges we have covered, 3 sessions are over, and 2.5 days program happens here. And once they go back with a lot of confidence, and it is very obvious, the success of the program is in the numbers which we do see. It is very heartening that the medical colleges which have been started very recently, they also have started certifying brain death. Theni, Tiruvaru, Dharmapuri, Krishnagiri. Recently, a couple of days ago even, Nilgiri's Medical College, they have done the first brain death and certification has happened. So I profusely thank our Dean and all the team members of the core team and the grief counselors and my faculty and my colleagues in Transplant for being part of all these important developments. But this is not enough. There is no room for complacency. We can't just remain buoyant based on this. Transplant has multiple other plans. It is a kind of a multi-pronged approach. I strongly believe that more and more of scientific temper has to creep into this program. We need to be having up-to-date and updated knowledge about every component of every solid organ transplant. So with that venture only, these kind of academics. On the one side academics, on the other side programs based focusing the public, on the other side training the stakeholders on every component of the disease donor transplant program. So like that, Transplant has got multiple plans, and this update series is one such. I thank once again our team for permitting us to do this, and this update series is done on behalf of Madras Medical College and Transplant together, and this will go on, sir. Actually, I'm planning, I'm a bit greedy. Every month we want to have one session. If not every month, at least once in 2 months we'll have sessions. Thank you. So let me have the pleasure of honoring our Dean with a shawl and I call upon Transplant.
It's a great honor to be this one of the greatest institute of India, and my sincere thanks to the member secretary Dr. Gopalakrishnan for inviting me to this as a orator in this for this August audience. I'm also very happy to say that my teachers, Professor Krishnamurthy, who taught me about hand transplant, is also one among the audience here to check whether I'm doing the right thing. Thank you so much, sir. So I just have a comprehensive presentation starting about the covering various points in hand transplant, and ensure that there will be take-home points for everyone, starting from the students and more for the transplant coordinators and few for the administrators and my colleagues. Okay, so what it matters for everyone is our alma mater, and I'm happy to share that where I'm studied, starting from Salem Vinaya Mission where I did my MS, and Government Rayapeta Hospital where I did my MBBS here at Rayapeta I did my MS, and Stanley Medical College and the Department of Plastic Surgery is a renowned hand surgery institute where I did my MCH and I laid the foundation for a microsurgery and did my cancer reconstruction at Tata Memorial, Mumbai. So again, I once again want to highlight my mentors and inspiration in hand transplant. Professor Krishnamurthy sir is here, and Professor Subramania Iyer. This is on the International Vascular Allograft meeting in New Delhi. So just to start from the history, Joseph Murray was the first one who did the first successful kidney transplant among twins, identical twins, and that's did in 1952. That's one of the first successful transplant in the world, and he received the Nobel Prize for the same in 1954. And what's interesting is he's a plastic surgeon. That's why I want to highlight that he's a plastic surgeon. And by the time the specialty grew a different way, and there has been a lot of changes among the organs, and finally each one took some organ, and finally a lot of things came under plastic surgery. And now plastic surgery evolved its own way, and we have something called as a reconstructive transplant, in which we take the hand transplant and face transplant. So hand transplantation, there's a lot of questions and debate among people saying that this is really necessary. I don't want to say any answer to this. Let me complete the presentation, and then I want the people to answer whether it's really, I want to understand you, you have to feel that really necessary or not. One thing I just want to make a point is, any surgery for that sake, if you want to do, it has to be done only if the surgeon is convinced about the procedure. You should be really into it and should know everything about it, and if he's convinced, then it works. So why to develop a hand transplant program in a country like India? We have mostly young males and maybe the sole earning members. The most commonly operate age is around 20 to 30 years, and loss of both hands is real severe disability. So for example, the first patient whom I did is around 23, and he has been, his mother used to bathe him every single day and make him used to wear his dress. Just realize such a situation at 21 years, still taken care by his mother. Then it's a psychologically and physically debilitating condition, especially patients who are born with hand and suddenly losing his hand. It's really terrible to think about it. And finally, it requires a caregiver for self-care and other activities of the daily living. So a hand transplant is a procedure. It's going to improve the quality of life, bringing the patient back to the family and society, avoiding a lifelong dependency, and also improves his self-esteem. So why can't we do processes can be done? So I've given some differences between the processes and hand transplant. There are a lot of processes called as bionic process. Starting from now, they've been quite cheaper. Starts from even 5 lakhs and ranges up to 25 to 30 lakhs. But the one thing that can never be given by a process at present is the sensation, which can never be matched with a hand transplant, and it has regular wear and tear, regular care, and in Indians where we are used for water for most of our cleaning purpose, this will not withstand water. So many other things I have mentioned. So there are some disadvantages, but the success of hand transplant in these cases depends upon choosing the right patient. I think that's the most important. If you choose the right patient, then it's a success. So this is a study by Bode and Bomahak about a 10-year study about what's hand transplant and the result of the initial of the 50 transplant in the world. He says 100% of the hand transplant in the world were surviving 2 years, and 100% patient gained protective sensation, and 94% of patients recovered their discriminatory sensation, and patients sufficient muscle regularity to be able to perform their daily activities. This is the report of the initial transplant program, and it is published, done by Board and Pomahak. So my today's talk will be what's the position of hand transplantation in India, and setting up a hand transplant program, what's the pre-operative preparation, the intraoperative task for surgeon, and the post-operative follow-ups, and finally the outcome. So India is a vast country, and whatever we say, we have we are the second most populous country in the world, and have the maximum, whatever we say, we have the maximum number in the world. So we have a 1.2%, 42 billion population, and the rough estimate as per one of the studies about 0.62 amputees per 1,000 population, and approximately more than 1 million amputees at a time. And apart from this, we have 2.4 lakh of burn victims added every year to this. So we have a huge, and what we actually require is we need a center to do this, so that caseload is already there. Only thing is, if the infrastructure has to be developed for the required patient. So India, where it started, the first Indian symposium, it has been the first world hand transplant happened in 1998 in Lyon, France, and the first hand transplant symposium, the world hand transplant was been promoted in India by none other than Professor Krishnamurthy, who is sitting right here. I think we have to congratulate that great man. And for him, he usually says, for him, one of his patient was the igniter. So what the patient asked him is, so why can't you put me another hand for a patient of another hand? So that stimulated him. From that day onwards, he was continuously saying the word hand transplant, and uses every possibility to learn about it, teach other colleagues, and even formed the program at Stanley Medical College, and it was immense help by Professor Vijay Korantla. And the first hand transplant happened in 2015 at Amrita. And we heard that news immediately within a week. Myself and Professor Krishnamurthy went there and visited the team. And then in September 2020, the first case in Mumbai. So again, I want to congratulate the transplant team in Tamil Nadu. The reason is the first hand transplant in Mumbai happened from a donor in Chennai. The hand was harvested. I did the harvest here. It was airlifted in a charter flight to Mumbai, and that was the first hand transplant in Mumbai. After that, they have done 10. I think, again, Tamil Nadu stands first in this case by being a part of the Mumbai hand transplant. And so far, around 260 cases has been done around the world, and this is around 3 months old data, and still it's increasing. So in India, the first is Amrita, the second is Jipmer, and third is Stanley, and fourth is the AFMC Pune, and then Mumbai Global, then followed by Chennai, then KEM Hospital Mumbai, then the Chennai Global, and recently last year 2 hospitals from Delhi, one is Faridabad Amrita and other is Gangaram Hospital, has done transplants. So this is the statistic I was just mentioning to our Honorable Dean. So at India it's around 69, and we stand first in the world till the last 6 months data. It's the last 6 months data. And again, the interesting feature is we have done the maximum number of bilateral hand transplant. The world over, a lot of people have done the unilateral, and we have done the maximum number of bilateral hand transplant in the world. So setting up a hand transplant unit, what we need is an institutional backup. What we actually mean is institutional backup is a center where already a transplant is going on. I think such a center will have all the infrastructure to harvest, and the logistics, a transplant coordinator, and all the legal operation they will know, so that the process becomes smooth. So the surgeon who wants to do can just follow his work, and the rest of the work will be carried out by the team. And definitely we have a lot of support we need from the administration, starting from the moral support, manpower, logistics, and especially in a private setup, it requires a lot of financial support, because most of these persons are from a low income group. So forming the team usually headed by the plastic surgeons in the hand transplant, orthopedician, anesthetist, and the paramedical staff. Here again, in my team, actually we are 4 full-timers and we are 4 part-timers are there. Apart from that, what I did is, so definitely that amount of surgeons might not be enough, because we need 4 teams working simultaneously. So we need a really big team for a smooth progress of the surgery. So we took some other person, including from government hospital. For example, for my last transplant, Professor G. Karthikeyan, who is sitting right here, helped me. He came and helped me. So we have all lot of talent pool lying in different hospitals among the both private and government setup in in Tamil Nadu. So we can take the help of doing this procedure. So number doesn't matter. What we require is a good infrastructure and the logistic to keep the work going. So immunological issues world over, the immunology part is carried by the nephrologist, and the same thing is done because it mostly resembles the kidney transplant, but the dose is slightly on a higher than a kidney transplant. So again, these all the things usually will be having in an already existing transplant center. One important thing is transplant pathology, because the reporting of the skin biopsy is slightly different from the other biopsy. That has to be little, the pathologist should be aware of that one. Then here, two things I like to mention is the preparing of the ancillary services. Two things are very important here, which is not involved in other transplant. First is the coordinator. Here again, once again, want to tell all the coordinators who are listening online and offline, when we remove a hand to a person, from a brain dead person, we always fix them with a prosthesis. We always respect the noble soul. We'll never give the body as a deformed body. This is the one point you have to educate all the donor family, because the moment they think they want to remove, because all other organs are internal organs, it will never be seen outside, taking a heart, liver, lungs, everything. But when you take a hand, the body appears mutilated. But inform them, we will provide with the processes, and when the body is covered, the body will never appear mutilated. I think this one point should be carried out to all the donor family by the coordinators. And other important thing is, so by again the kidney, liver, other thing, once we ensure the blood supply, they start functioning. But it's not the same with hand. Here we require the nerve recovery and that muscle function. That comes over the time. So the muscle nerve grows at a rate of 1 millimeter per day. So depending on the level of transplant which we do, it may vary from 6 months to 1 year or even 2 years for a transplant at the shoulder level. So the physiotherapists and occupational therapists are very, very important part in a hand transplant team. Then we establish a protocols like inclusion criteria, exclusion criteria, and the procedure, how we are going to follow for each level of transplant, the immunological thing, and depending on the institution we should frame a protocol, and regular meetings should be happen among them. And a good infrastructure, again, this will be available in all the places where already transplants are going, because they need a separate very much sterile room, so that these immunocompromised patients to the initial few days are free of any infection. And for a hand surgery, we need everything in two. In fact, we need 4 tables. For example, if it's a double hand transplant, when the hand comes from other area, that 2 hand has to be dissected out, and the recipient 2 hand has to be dissected out. So there is 4 teams working simultaneously. So you should have that much of instruments and theatre setup to operate 4 tables simultaneously, including the manpower. So, and as I already said, the success of the procedure depends upon the proper patient selection. To be honest, I have seen more than 50 patients in the last 5 years who has come for hand transplant, and I have registered only 5 patients among them, in which 3 of them I have operated. Because the patient, just like that, for example, one patient came, he has been living with a snappy for more than 25 years, suddenly one says, I want a hand transplant. I asked why? He said, I want to die with a hand. See, that is not the purpose for a hand transplant, just putting an organ. A noble soul is donating a hand, and that has to be used properly lifelong, and this should improve the quality of life for this patient. So we should choose the right patient, then only they follow the immunosuppression properly. Another thing is the first hand transplant which happened in Lyon, that patient was New Zealand, he was transported to Lyon, and the surgery was done. The hand was removed in 6 months because the patient was not taking the immunosuppressants properly. So proper counseling and selection of patients is the most important thing for the success of this procedure. And again, exclusion criteria, generally unilateral we always keep as a second option, because their dash score is quite less, and people will be seeing with a single dominant hand they will be able to do most of their function. But still unilateral can be considered in certain cases if it affects their life function, and if the patient is psychologically affected because of the loss of that hand and not able to do their function because of the loss of the hand, and if it is more preferable if it is a dominant hand. And severe medical conditions like malignancy, HIV infection, then pediatric amputee is less than 18 years we don't take, because the risk of malignancy is very high, since we are using a bone marrow also in them. And again, poor family support, I like to mention, if a patient doesn't have good family support, this procedure should never be done because it needs a lifelong immunosuppression and proper care and taking them to the hospital back. And in case of any complication, they should be there to support them both psychologically and physically. So this is the inclusion criteria, what we take bilateral, most commonly it's a bilateral, and the age between 18 to 60 years, then psychologically stable, financial stability, and good family and social support. And once we form the team, increase the public awareness so such things are possible, so a deserved patient can can approach for a transplant. So in Chennai at present, I think we have more than 3 hospitals, including the government Stanley Hospital has the license. So the patient can approach the hospital for a hand transplant. And again, conducting like a CME like this can carry the message to a much larger population, including the students who are budding doctors. They'll be aware of such things are happening. They can spread the news among a larger population. Then training. So hand transplant is just not like a replant. It needs an additional care apart from the transplant. So this is again an ongoing process. We just did training. This is the Amrita Institute. I went to Amrita Institute where they did more than 3 transplants. That time we went there to learn the nuances and what they have done for the previous cases. And in ISOT, in the Indian Society of Organ Transplant, every year they have a separate session for hand transplant, so which we attend. And we call a year to our place to teach to sensitize our people. And there's a cadaver workshop happened in India in 2 or 3 places. So these are the things which we can acclimatize with these procedures. It's a new novel procedure and learn small things from each opportunity. This is a touching session at KEM Hospital, Mumbai. So once we are ready, then we can apply for the license. So they came for an inspection, they look for all the available things, and then we get the license. And here again, I like to thank the Tamil Nadu government and the Transplant, because for our first case, it's the most difficult case to get the things running. For the first case, when we did, our license got expired, and it was the middle of the COVID time. So because of the logical issue, they were not able to come for inspection and get the license. So, but we had a recipient and there was a donor was available. And when we approached the government, within 3 hours we got the temporary license for that one patient. I think this could never happen anywhere in the world. Because I think sincerely thank the Transplant and Tamil Nadu government for giving such a short notice, because they don't want to waste an organ. And thus, I will just show that patient later. So we got that license. So they came for inspections and we got the license. So once we got the license, then only we have to register the patient. So these are a few of our patients who have registered. And this is actually an interesting case, a father-son duo having a bilateral amputee. Both had a bilateral amputation. And these are the last of unilateral amputees, except for the first one. We have not processed with all other people. We have not registered them because the reasons are totally different. A good candidate, and we never register them at the first counseling. We minimum give of 2-3 counselings, saying all the positive and negative aspect of this procedure, then only we proceed with the surgery. Then we go with the anatomic evaluation and the surgical planning. And like any other transplant, what we require here is the ABO incompatibility, so blood group match. Even the gender mismatched donor can be taken. For a male can donate to a female and a female can donate to a male. And similarly, and a lymphocyte cross match. These 2 things are done before the transplant. This I already mentioned. They need a little bit of support from the family, both financially and physically, so that the patient is able to maintain the hand for his immunosuppressive medication. Here again I like to thank the government, because for a patient who was done in a private hospital, they are supplying the immunosuppressive drugs are given free from the government. Again, I like to thank the government, because it is a huge burden for them. So though it was done in the private setup, the government is sponsoring them all the drugs. And selection criteria, so this all we mentioned. So basic ABO thing is done, and depending on the level of our transplant which we have to do, we prepare the processes ready, so that whenever an alert comes, we go with the processes. So the surgical technique, we usually go one step ahead, one level ahead to harvest, so that we need a large amount of skin, nerves, muscles everywhere. So we take usually, if the recipient hand is a distal forearm, we harvest at the elbow level. We take a little longer level, so that a longer nerve and vessels are available for the anastomosis. So though it is so we are going to harvest a hand, all the aseptic precautions should be done, because because the patient who is going to receive is highly immunocompromised, and any infection in this donor organ can affect the patient recipient. And once again, I want to mention here is hand transplant will not have any blood loss or a great hemodynamic instability to the patient. So initially patients, when the liver, kidney, they are usually, there's a routine for them, they come and harvest, and when the hand comes, they say, when are you coming? Either please harvest after the our harvest. But I just want to say again, once again here, hand is harvested in outstretched position. So still the liver, kidney and heart transplant can go simultaneously, one, and there's no chance of hemodynamic instability, because not more than 10 to 15 ml of blood loss is going to be there, because we completely harvest under tourniquet. So there will not be any they can just go simultaneously with other hand transplant, other organ transplant. I can just show, so immediately after the transplant, we fit them with the processes. So I just have a short video about the mid-arm level. This is for one of our, this is the hand which we harvested for the Mumbai. So when we harvest, we just harvest as like a guillotine amputation. We don't take, because we want to reduce the warm ischemia time. So, and the remaining all we can do is the cold ischemia. So the initial is done like a guillotine amputation, and the harvest hardly takes 7 to 10 minutes. It will not take more than that. It will take only 7 to 10 minutes, and you can literally see how much blood is lost. Not more than 10 to 15 ml per side, and it is done an outstretched hand. And one moment it's we harvest the hand, we put them on the UW solution and start infiltrating it till we get a clear solution. So, and again this harvest is going simultaneously in the other side also. So more than, not within 15 minutes both the hand will be harvested. It's not more than that. And the tourniquet will be released at the end of all the harvest, so that there is no bleeding at all. You see that this hand is harvested, by the time the other hand arrives, and we flush it with to remove all the blood till we get a clear fluid. You can see the clear fluid coming out. This is the stage we end the perfusion, and then this hand is immediately packed and put in the ice box to the transport. And as I already mentioned, there will not be any blood loss. We put the tourniquet, and the tourniquet is removed after all the other organ transplant is completed, so that there is no hemodynamic instability because of the hand harvest. So we pack it, label it, and put it in the ice box like any other transplant. And finally fit them with the processes before handing over the body to the patient attendants. This is another case. You can just see these processes which usually comes even with nails. So even for example, in some community, for example Christians, they used to keep the hand out for the prayer. Even it looks like that. If in bilateral it both appear similar, and will not appear any different. The hand can still be shown, and we try to match the color also by up to 80% for the processes. And there are a lot of time-is tissue, especially for hand where the muscle is involved. We try to join the vessels by maximum 6 hours. So there are a lot of protocols to be followed in that, and in areas where other transplants are already going on, this is just the coordinators will take care of most of the work. Nothing has to be done by surgeon. The coordinate, but when we did for the first time, it was very nice to see how the things work, ensuring a clean corridor, flight timing. So here, most of the time, the hand comes from other places. You work in reverse. For example, if the flight time is 4 o'clock, then we start the harvest just closer to that time, within at 3 o'clock, and calculate the time, how much time to the airport. And people are so grateful to arrange for the green corridor, and in the government officials and in the airport, they give so much clearance. We just able to do it, in the very shortest time possible. And one thing is when, and here having the permission to carry the ice box, here again one interesting thing is whenever we carry the organ, it is put on the patient's, in a passenger seat. It's not carried in the cargo. It's a big box. We have to take a separate ticket for the organ, and it has to be placed next to us. So it was a totally different feeling when the first time I carried an organ. I think it was a doctor. Everyone who is sitting next to me, the passengers, just taking the hand and blowing. I don't know the reason, but first time I had a totally different feeling of my life. Taking an organ to other place, they actually, I don't know how to express that feeling, but it was totally, because the organ is next to me and they're putting flowers over it, and the people who are sitting in all the co-passengers, more than 200 passengers, I don't know whom they are, but they still wished everything should go good. I think one of the greatest experience when we had carried the organ. And then finally the preparation. Once we get the hand, we split into many parts. I think sir was, Gopalakrishnan sir was telling. So we separate the hand with all the nerves, muscles, tendons, everything will be separated. Both the extensor, flexor, everything will be separated, and each one will be labeled. And then you can see all the parts will be labeled, and then each has to be joined separately. And among the transplants which is happening here, this is the most difficult transplant I can say, because it is not just joining the blood vessels and the nerves. All the tendons and the tendons should be matched properly, and that should be fixed with a proper tension. Then only the post-operatively the function comes back. So all the muscles, more than 15 tendons, 15 to 20 tendons has to be, and more 3 nerves and 4 to 6 blood vessels has to be joined, and all the tendons will be done in the right tension to bring back the function. So this is the organ we dissect, this is the donor site which we have dissected, then finally both are joined. And here we take the help of the orthopedician to fix the bones with the plates and screws, then we come to the soft tissues. Bone fixation, muscle repair, then immediately the vessel anastomosis, then after the vessel anastomosis we do the tendon coaptation, nerve anastomosis, and finally the skin closure. It is similar to replant, but in a more control over tissues. And simultaneously, the immunosuppression medication also going on, which will be taken care by our nephrologist. And I'm very happy to say that our nephrologist used to say, this is the first time I'm giving all the immunosuppressive medication without seeing the urine output. Because all our young patients, they never want to see the urine output. They just give the immunosuppressive drugs without seeing the urine output. So this is just want to highlight how did our first patient. Is a 29-year male, the donor of the 30 years. So this was his pre-op. And we took the organ from Ahmedabad, and it's around 1,800 kilometers. And again, this is probably the most distant traveled hand in the world. It's around 1,800 kilometers travel, and the surgery was done. And the surgery total, and it was involved 8 plastic surgeons, 4 orthopedicians, 4 anesthesiologists, and the big team was involved, 16 hours procedure. And for this, the purpose which we received the honor from the Honorable Vice President of India for the first successful below elbow transplant. And you can see this was his pre-op, and this was his 1 year, and this was happened 1.5 years. And this is our second bilateral hand transplant. It's doing very well. It's recovering now and he's on physiotherapy now. This is our third patient is a unilateral. And as Robert Auckland, a microvascular surgeon, who told preparation is the key to success. Actually, this is me and my colleague Dr. Nilesh from Mumbai Global. We were practicing in the same cadaver at Delhi AIMS. So he did the first hand transplant in 2010, and 2020 I did in 2022. So we did it and helped each other in the procedure. So actually, what is more important is the preparation is the most important thing for any procedure. And this is our patient who is undergoing the physiotherapy now. He is now 10 weeks post-op. And even by this time, his DASH score has come down by more than 40. DASH score is a score which is used to assess the transplant outcome, and we just keep on learning. We just try to attend all the possible, because it's a very less number, and so we keep on seeing all the possible, because it's a very small group of people who are doing this work, so we try to share the knowledge with each other and share it during the conference. And this is the person, I think, who is the first, he's a part of the team who done the first successful hand transplant in the world. He came to India for another reason, so we invited him to give his opinion about the hand transplant. We had a talk, and Professor Krishnamurthy sir is also here. So the unique consideration in hand transplant is the poor donor availability. As I already mentioned, is because they see the body is mutilated, and there's a size and color match. And bilateral is unilateral, as I already mentioned, bilateral always gets the first preference, and unilateral only in very selective conditions. And one interesting thing is tacrolimus has a nerve regeneration potential. So normally we say the nerve regenerates 1 millimeter per day, but when you give tacrolimus, what we have seen is it grows more than 2 millimeter per day. The Valerian regeneration is very faster because of tacrolimus. And again, after the procedure, they have to go for his, the thumb, they have to redo with their Aadhaar card and other identification, because it's a different thumb. And they also have to erase this thumb from of the donor also. They have to send a request, so because they're getting a new identification. Yes, rejection episodes happen. We do have complication. This is our first patient who had so far had 2 episodes in the first 3 months, and after that he is doing well. And we have enough medicines like any kidney or liver. We have enough medicine. Only thing we have to recognize it. And again, here I want to say, hand transplant is one of the very easiest thing to identify the rejection. In kidney, you doesn't know. Liver, you have to take a biopsy. It becomes a long process. Here, hand, the moment you see there is a rash, able to identify. Skin is so immunological. We are able to see the rash, and the next day we will be able to start the issue. And so far in the world, whatever they done, more than 90% of the cases have rejection only in the first 6 months. After that, the process is very smooth. And so far in the world, only 2 patients have died because of hand transplant. And it's a team, it's not a single one, so it's a whole team is involved in it. I'm just saying only the team in global hospital, but so many other well-wishers are around here who has helped me, including the Karthikeyan sir is here. And in India, we relate everything to the cricket. So this, hand transplant also similarly, everything should be in the proper place for the things to go on. So it's a large task which needs intensive planning and cooperation from various teams within and outside the institution. Suitability of the recipients is the first step. Intense post-operative rehabilitation leads to the ultimate success. Just small video, I just want to show, it's just a 4-minute video about how it can change the life. You can see. Can I have the volume?
ஸ்பீக்கரில் தான் வருது சார்.
வயசு 21 வயசாச்சு. இந்த 21 வயசில் என்னோட வாழ்க்கையை தலைக்கு தான் மாறிடுச்சு. அப்படி இருக்கும்போது ஒரு தண்ணி குடிக்கணும்னா கூட அப்பா எதிர்பார்க்கணும், குளிக்கணும்னா கூட அம்மா வந்து குளிச்சுட்டு அவங்க எதிர்பார்த்தா இருக்கணும், சாப்பாடு வைக்கிறதும் அம்மா தான். இப்போ சப்போஸ் ஒரு மெசேஜ் பண்ணணும் அப்படின்னா கூட யாரைனா ஒருத்தர் எதிர்பார்த்து தான் இருக்கணுன்ற மாதிரி ஆயிடுச்சு. என் வாழ்க்கையே வந்து ஒருத்தர் எதிர்பார்த்து தான் இருக்கணுன்ற மாதிரி ஆயிடுச்சு. ஒரு டீ கடை வச்சுருக்கேன். டீ கடையில் வந்து கூடமான எதிர்பார்க்கணுமா பையனுக்கு போது ஒரு சந்தோஷமா பார்த்தேன். நம்ம பையனுக்கு வந்து சாப்பிட்றேன், நம்மளாம் நல்லா சாப்பிட்றேன் சொல்லிட்டு ஒரு நிறைய பேர் கேட்டாங்க, பிளாஸ்டிக் கேன் வச்சுக்க போறியா, இல்லை ரோபோட்டிக் கேன் வச்சுக்க போறியா அப்படின்னு சொல்லி ரோபோட்டிக் கேன் ட்ரை பண்ணி பார்த்தேன். இருந்தாலும் ஒரு ஃபீல் ஆகலை, நம்ம கையால் டச் பண்ணுற ஃபீல் ஆகலை அப்படின்றதுனால அப்புறம் 1 நியூஸ் பேப்பரில் வந்து ஹேண்ட் டிரான்ஸ்பிளான்ட் அப்படின்னு சொல்லி ஒரு விஷயம் இருக்குது அப்படின்றத பார்த்துட்டு அதுக்கப்புறம் எங்கள் சித்தப்பா கூகுள் பண்ணி பார்த்தேன். சர்ஜரி நடந்த நாள் காலையில் வழக்கம் போல் ரன்னிங் போயிட்டு வந்தேன். ஐ காட் அலர்ட், இந்த மாதிரி அகமதாபாத்லேருந்து ஒரு ஹேண்ட் டிரான்ஸ்பிளான்ட் டோனர் இருக்காங்கன்னு சொல்லிட்டு. ஸோ எமர்ஜென்சியாக ஹாஸ்பிட்டல் அத்தாரிட்டிக்கு இன்ஃபார்ம் பண்ணி அதுக்கு அடுத்த ஒரு நடவடிக்கை எல்லாம் மேற்கொண்டோம். ஸோ அங்கே ஹார்வெஸ்ட் பண்ணுற அதே டைமில் வெங்கடேஷ்க்கு இங்கேயும் சர்ஜரி ஆரம்பித்தோம். அந்த ஹார்வெஸ்ட் பண்ணிவிட்டு இமீடியட்டாக அடுத்த ஃப்ளைட்டில் அந்த ஹேண்ட் பேக்கை கொண்டு வந்தோம். நீ இறந்துட்டு இருக்கலாம் இருக்குது அப்படின்னு சொல்லிட்டாரு. துடுப்பில்லாத படகு ஏதோ ஒரு நாள் ஒரு கரையை பிடிச்சதுன்னு சொல்லுவாங்க. கூட என்னோட ட்ரைனர் கேட்டார் வலிக்கலையா அப்படின்னு சொல்லி 3 வருஷமா நான் பார்த்த அவமானத்தை விட ஒன்றும் பெருசாக வலி இல்லை அப்படின்னு சொல்லி தொலைச்ச வாழ்க்கை மறுபடியும் திருப்பி கிடைச்ச மாதிரி. ஏன்னா 29 ஆப்ரேஷன் 2 பர்த்டே இதுலேருந்தே தெரிஞ்சிருக்கும் என்னோட வாழ்க்கை மறுபடியும் ஸ்டார்ட் ஆகிடுச்சு அப்படின்றது. என்னோட லைஃப் எதை எதிர்பார்த்துருக்கோ அது நடந்துருச்சு. ரொம்ப ஹாப்பியாக இருக்கேன். அப்புறம் எனக்கு ஹேண்ட் கொடுத்தாங்க ஃபர்ஸ்ட் அவங்களுக்கும் அவங்க ஃபேமிலிக்கும் ரொம்ப தேங்க்ஸ் சொல்லணும். ஏன்னா அவங்க இல்லைன்னா எனக்கு இல்லை. ஏன்னா என்னோட லைஃப்பை மறுபடியும் ஸ்டார்ட் பண்ணுறவங்க அவங்க தான்.
very big
Actually, the patient attendant had a tattoo. The patient who donor had a tattoo, but still he retains the tattoo. And this is again one interesting thing is the one who has donated, they can touch their. This is the only organ they can feel after this transfer also after the transplant. This last 2 slides. Finally, I want to say, with it,
No, sir. 1 minute, sir. 1 minute, sir.
Okay, so that's just last but one slide. Finally, just want to repeat the slide which I first showed, the first one. Is it really necessary? I think the jury is out. You can feel what a hand transplant, what a quality of life they can get back. And that I again want to say 2 things. One, the success depends upon proper patient selection. That's the most important thing. Second thing, the surgeon himself should get convinced about the procedure. And if you do 2 things, the rest of the government support and infrastructure and whatever and all things will follow you. And you can do a real big difference to the patient. Thank you so much.
I am sure you all will agree with me that it was a wonderful experience to go through. The kind of a feeling. It is not just a professional challenge. Actually, it is a lot of emotions tagged with this. I was very successful in sharing those emotional component as well. Now the floor is open for discussion on the scientific content of the procedure. Before that, it's our privilege to honor the mentor of today's guest speaker. May I request Professor Krishnamurthy to receive the honors, and I request our Professor of Plastic Surgery, Professor Sukumar, to do honors for him.
ப்ரெஷர் இருக்குது அவங்க நான் நிற்க வச்சு கரெக்டாக இருக்கும் கேமரா
It's time for interaction, and after the interactive session is over, please join us for lunch. We made an arrangement for lunch as well.
The organ transplant is completed so that there is no hemodynamic instability because of the hand harvest. So we pack it, label it, and put it in the ice box like any other transplant. And finally fit them with the processes before handing over the body to the patient attendants. This is another case. You can just see these processes which usually comes even with nails. So even for example, in some community, for example Christians, they used to keep the hand out for the prayer. Even it looks like that. If in bilateral, it both appear similar and will not appear any different. The hand can still be shown, and we try to match the color also by up to 80% for the processes. And there are a lot of time is tissue, especially for hand where the muscle is involved. We try to join the vessels by maximum 6 hours. So there are a lot of protocols to be followed in that, and in areas where other transplants are already going on, this is just the coordinators will take care of most of the work. Nothing has to be done by surgeon. The coordinate, but when we did for the first time, it was very nice to see how the things work, ensuring a clean corridor, flight timing. So here, most of the time, the hand comes from other places to work in reverse. For example, if the flight time is 4 o'clock, then we start the harvest just closer to that time, within at 3 o'clock, and calculate the time, how much time to the airport. And people are so grateful to arrange for the green corridor, and in the government officials and in the airport, they give so much clearance. We just able to do it, in the very shortest time possible. And one thing is here having the permission to carry the ice box. Here again, one interesting thing is whenever we carry the organ, it is put on the patient's, in a passenger seat. It's not carried in the cargo. It's a big box. We have to take a separate ticket for the organ, and it has to be placed next to us. So it was a totally different feeling when the first time I carried an organ. I think it was a doctor. Everyone who is sitting next to me, the passengers, just taking the hand and blowing. I don't know the reason, but first time I had a totally different feeling of my life. Taking an organ to other place, they actually, I don't know how to express that feeling, but it was totally because the organ is next to me and they're putting flowers over it, and the people who are sitting, all the co-passengers, more than 200 passengers, I don't know whom they are, but they still wished everything should go good. I think one of the greatest experience when we had carried the organ. And then finally the preparation. Once we get the hand, we split into many parts. I think Gopalakrishnan sir was telling. So we separate the hand with all the nerves, muscles, tendons, everything will be separated. Both the extensor, flexor, everything will be separated, and each one will be labeled. And then you can see all the parts will be labeled, and then each has to be joined separately. And among the transplants which is happening here, this is the most difficult transplant I can say, because it is not just joining the blood vessels and the nerves. All the tendons and the tendons should be matched properly, and that should be fixed with a proper tension. Then only the post-operatively the function comes back. So all the muscles, more than 15 tendons, 15 to 20 tendons has to be, and more 3 nerves and 4 to 6 blood vessels has to be joined, and all the tendons will be done in the right tension to bring back the function. So this is the organ we dissect, this is the donor site which we have dissected, then finally both are joined. And here we take the help of the orthopedician to fix the bones with the plates and screws, then we come to the soft tissues. Bone fixation, muscle repair, then immediately the vessel anastomosis, then after the vessel anastomosis we do the tendon coaptation, nerve anastomosis, and finally the skin closure. It is similar to replant, but in a more control over tissues. And simultaneously, the immunosuppression medication also going on, which will be taken care by our nephrologist. And I'm very happy to say that our nephrologist used to say, this is the first time I'm giving all the immunosuppressive medication without seeing the urine output. Because all our young patients, they never want to see the urine output. They just give the immunosuppressive drugs without seeing the urine output. So this is just want to highlight how did our first patient. Is a 29-year male, the donor of the 30 years. So this was his pre-op, and we took the organ from Ahmedabad, and it's around 1,800 kilometers. And again, this is probably the most distant traveled hand in the world. It's around 1,800 kilometers travel, and the surgery was done. And the surgery total, and it was involved 8 plastic surgeons, 4 orthopedicians, 4 anesthesiologists, and the big team was involved. 16 hours procedure. And for this, the purpose which we received the honor from the Honorable Vice President of India for the first successful below elbow transplant. And you can see this was his pre-op, and this was his 1 year, and this was happened 1.5 years. And this is our second bilateral hand transplant. It's doing very well. It's recovering now and he's on physiotherapy now. This is our third patient is a unilateral. And as Robert Auckland, a microvascular surgeon, who told preparation is the key to success. Actually, this is me and my colleague Dr. Nilesh from Mumbai Global. We were practicing in the same cadaver at Delhi AIMS. So he did the first hand transplant in 2010, and 2020. I did in 2022. So we did it and helped each other in the procedure. So actually, what is more important is the preparation is the most important thing for any procedure. And this is our patient who is undergoing the physiotherapy now. He is now 10 weeks post-op. And even by this time, his DASH score has come down by more than 40. DASH score is a score which is used to assess the transplant outcome, and we just keep on learning. We just try to attend all the possible, because it's a very less number, and so we keep on seeing all the possible, because it's a very small group of people who are doing this work. So we try to share the knowledge with each other and share it during the conference. And this is the person, I think, who is the first. He's a part of the team who done the first successful hand transplant in the world. He came to India for another reason, so we invited him to give his opinion about the hand transplant. We had a talk, and Professor Krishnamurthy sir is also here. So the unique consideration in hand transplant is the poor donor availability. As I already mentioned, is because they see the body is mutilated, and there's a size and color match. And bilateral is unilateral. As I already mentioned, bilateral always gets the first preference, and unilateral only in very selective conditions. And one interesting thing is tacrolimus has a nerve regeneration potential. So normally we say the nerve regenerates 1 millimeter per day, but when you give tacrolimus, what we have seen is it grows more than 2 millimeter per day. The Valerian regeneration is very faster because of tacrolimus. And again, after the procedure, they have to go for his, the thumb. They have to redo with their Aadhaar card and other identification, because it's a different thumb. And they also have to erase this thumb from of the donor also. They have to send a request. So, because they are getting a new identification. Yes, rejection episodes happen. We do have complications. This is our first patient who so far had 2 episodes in the first 3 months, and after that he is doing well. And we have enough medicines, like any kidney or liver. We have enough medicine. Only thing we have to recognize it. And again, here I want to say, hand transplant is one of the very easiest thing to identify the rejection. In kidney, you doesn't know. In liver, you have to take a biopsy. It becomes a long process. Here, hand, the moment you see there is a rash, you're able to identify. Skin is so immunological, we're able to see the rash, and the next day we will be able to start the issue. And so far in the world, whatever they've done, more than 90% of the cases have rejection only in the first 6 months. After that, the process is very smooth. And so far in the world, only 2 patients have died because of hand transplant. And it's a team, it's not a single one, so it's a whole team is involved in it. I'm just saying only the team in global hospital, but so many other well-wishers are around here who has helped me, including G. Karthikeyan sir is here. And in India, we relate everything to the cricket. So this, hand transplant also similarly, everything should be in the proper place for the things to go on. So it's a large task which needs intensive planning and cooperation from various teams within and outside the institution. Suitability of the recipients is the first step. Intense post-operative rehabilitation leads to the ultimate success. Just small video, I just want to show, it's just a 4-minute video about how it can change the life. You can see. Can I have the volume?
இல்லை மைக் இங்கே வச்சிடலாமா அதெல்லாம் கனெக்ட் ஆகிடும் மைக் அங்கே தான்
எங்கே வருது?
நாங்கள் ஸ்பீக்கரில் தான் வருது சார்.
வயசு 21 வயசாச்சு. இந்த 21 வயசில் என்னோட வாழ்க்கையை தலைக்கு தான் மாறிடுச்சு. அப்படி இருக்கும்போது ஒரு தண்ணி குடிக்கணும்னா கூட அம்மாவை எதிர்பார்க்கணும், குளிக்கணும்னா கூட அம்மா வந்து குளிச்சுட்டு அவங்க எதிர்பார்த்தா இருக்கணும், சாப்பாடு வைக்கிறதும் அம்மா தான். இப்போ சப்போஸ் ஒரு மெசேஜ் பண்ணணும் அப்படின்னா கூட யாரைனா ஒருத்தர் எதிர்பார்த்து தான் இருக்கணுன்ற மாதிரி ஆயிடுச்சு. என் வாழ்க்கையே வந்து ஒருத்தர் எதிர்பார்த்து தான் இருக்கணுன்ற மாதிரி ஆயிடுச்சு. ஒரு டீ கடை வச்சுருக்கேன். டீ கடையில் வந்து குடும்பமான எதிர்பார்க்கணுமா
பையனுக்கு போது ஒரு சந்தோஷமா பார்த்தேன். கை போட்டு பார்த்தேன். அப்படியே அவங்க சொன்னாங்க காசு.
நம்ம பையனுக்கு வந்து இப்போ சாப்பிட்றேன், சரி முன்னாடி நம்மளாம் நல்லா சாப்பிட்றேன் சொல்லிட்டு ஒரு நிறைய பேர் கேட்டாங்க பிளாஸ்டிக் கேன் வச்சுக்க போறியா இல்லை ரோபோட்டிக் கேன் வச்சுக்க போறியா அப்படின்னு சொல்லி ரோபோட்டிக் கேன் ட்ரை பண்ணி பார்த்தேன். இருந்தாலும் இது ஒரு ஃபீல் இல்லாத நம்ம கையால் டச் பண்ணுற ஃபீல் ஆகல அப்படின்றதுனால அப்புறம் ஒன்றா நியூஸ் பேப்பரில் வந்து ஹேண்ட் டிரான்ஸ்பிளான்ட் அப்படின்னு சொல்லி ஒரு விஷயம் இருக்குது அப்படின்றத பார்த்துட்டு அதுக்கப்புறம் எங்கள் சித்தப்பா கூகுள் பண்ணி பார்த்தேன். சர்ஜரி நடந்த நாள் காலையில் வழக்கம் போல ரன்னிங் போயிட்டு வந்தேன். ஐ காட் அலர்ட், இந்த மாதிரி அகமதாபாத்லேருந்து ஒரு ஹேண்ட் டிரான்ஸ்பிளான்ட் டோனர் இருக்காங்கன்னு சொல்லிட்டு. ஸோ எமர்ஜென்சியாக ஹாஸ்பிட்டல் அத்தாரிட்டிக்கு இன்ஃபார்ம் பண்ணி அதுக்கு அடுத்த ஒரு நடவடிக்கை எல்லாம் மேற்கொண்டோம். ஸோ அங்கே ஹார்வெஸ்ட் பண்ணுற அதே டைமில் வெங்கடேஷ்க்கு இங்கேயும் சர்ஜரி ஆரம்பிச்சோம். அந்த ஹார்வெஸ்ட் பண்ணிட்டு இமீடியட் அடுத்த ஃப்ளைட்டில் அந்த ஹேண்ட் பேக்கை கொண்டு வந்தோம். நீ இறந்துட்டு இருக்கலாம் இருக்குது அப்படின்னு சொல்லிட்டாரு. துடுப்பில்லாத படகு ஏதோ ஒரு நாள் ஒரு கரையை முடிச்சதுன்னு சொல்லுவாங்க. அது போல தான் நானும் ஒரு கரையை முடிச்சுட்டேன். இப்போ கூட என்னோட ட்ரைனர் கேட்டார் வலிக்கலையா அப்படின்னு சொல்லி. 3 வருஷமா நான் பார்த்த அவமானத்தை விட ஒன்றும் பெருசாக வலி இல்லை அப்படின்னு சொல்லி தொலைச்ச வாழ்க்கை மறுபடியும் திருப்பி கிடைச்ச மாதிரி. ஏன்னா 29 ஆப்ரேஷன் 2 பர்த்டே இதுலேருந்தே தெரிஞ்சிருக்கும் என்னோட வாழ்க்கை மறுபடியும் ஸ்டார்ட் ஆகிடுச்சு அப்படின்றது. என்னோட லைஃப் எதை எதிர்பார்த்துருக்கோ அது நடந்துச்சு. ரொம்ப ஹாப்பியாக இருக்கேன். அப்புறம் எனக்கு ஹேண்ட் கொடுத்தாங்க. மோஸ்ட்லி அவங்களுக்கும் அவங்க ஃபேமிலிக்கும் ரொம்ப தேங்க்ஸ் சொல்லணும். ஏன்னா அவங்க இல்லைன்னா எனக்கு இல்லை. ஏன்னா என்னோட லைஃப்பை மறுபடியும் ஸ்டார்ட் பண்ணுறவங்க அவங்க தான்.
very big.
Actually, the patient attendant had a tattoo. The patient who donor had a tattoo, but still he retains the tattoo. And this is again one interesting thing is the one who has donated, they can touch their. This is the only organ they can feel after this transfer also after the transplant. Just last 2 slides. Finally, I want to say, is it,
No, sir. 1 minute, sir. 1 minute. 1 minute, sir.
okay. Okay, so that's the just last but one slide. Finally, just want to repeat the slide which I first showed, the first one. Is it really necessary? I think the jury is out. You can feel what a hand transplant, what a quality of life they can get back. And that I again want to say 2 things. One, the success depends upon proper patient selection. That's the most important thing. Second thing, the surgeon himself should get convinced about the procedure. And if you do 2 things, the rest of the government support and infrastructure and whatever and all things will follow you. And you can do a real big difference to the patient. Thank you so much.
I am sure you all will agree with me that it was a wonderful experience to go through. The kind of a feeling. It is not just a professional challenge. Actually, it is a lot of emotions tagged with this. I was very successful in sharing those emotional component as well. Now the floor is open for discussion on the scientific content of the procedure. Before that, it's our privilege to honor the mentor of today's guest speaker. May I request Professor Krishnamurthy to receive the honors, and I request our Professor of Plastic Surgery, Professor Sukumar, to do honors for him.
சார் அவங்க நாம நிற்க வச்சு கரெக்டாக இருக்கும் கேமரா
It's time for interaction, and after the interactive session is over, please join us for lunch. We made an arrangement for lunch as well.
Dr. Gopal Renjiki sir and my teacher Dr. Krishnamurthy sir and colleagues, senior colleagues GK sir and others, and my dear colleagues and the great audience. Actually, it is a pleasure to start this discussion. Actually, I was part of this hand transplant. That's why I have some few words in initiating this discussion. Actually, the hand transplant, first it was done in India by the Amrita Institute. Then, actually, Dr. Krishnamurthy was initiating, before the hand transplant in Amrita itself, he has started the getting license for the hand transplant in Stanley. But we could not get the proper that is donor for the recipients, because many people were registering. So after the Dr. Krishnamurthy's retirement, and when I was because I was in Stanley for almost 14 years as assistant professor. So first time in December 2017, we had the opportunity for the hand transplant. That day I was on duty. So I was counseling we called for the many recipients. I was counseling each recipients. I told about the immunological problems and lifelong immunosuppression and the pros and cons of the hand transplant and complete outcome, because in hand, the problem in the hand transplant is all other organ transplants they are involuntary organs, but the hand is the voluntary organ. So that is the main problem. So it needs the brain to control and it has to act from the control. So it is a voluntary organ. That is the problem, because there you need nerve and bigger for the sensation and the motor function, everything you need more care. So we told the pros and cons, all have gone. So nobody was willing that December. So we started, but we failed. But in February, the next within 3 months, February 7th, we had another chance. Then we have counseled one particular patient, Narayana Sami, for the in presentation for the just for a correction. The first hand transplant in the government setup was done by the Stanley in Tamil Nadu, not by the Jipper, because after only the Jipper has done, the Dinesh has done that hand transplant. So first in Tamil Nadu is Stanley, and first among all the government institutions in India, it is only in Stanley. That is the hand transplant. So that time we had the problem was in the hand transplant is we have counseled and we have started the hand transplant. It has taken almost 13 hours for the hand transplant. Morning 6 o'clock we have started and we have completed by 7 o'clock, because it was the first time. We don't have any experience, we don't have any workup or anything. So just like that we have started. I myself only I have discussed with that is with the Amrita people. Mogit only I have discussed, and we planned and we have done almost the workers we have involved was 75 workers. Almost the doctors itself almost around 20 people. We had excellent anesthetic, because in hand transplant the surgery is okay, but the anesthetic backup is very, very important. If you don't have the proper anesthesia team, then you will be caught up in a problem. So we had an excellent anesthetic, because at one point of time the patient had the drop of bradycardia. He has gone to the 40-30 bradycardia, and BP also drastically fall. But they never passed the tension to the surgeons. They have managed excellently. Then we have smoothly we sailed through. But the only problem is it has given a lot of impact on the department. Almost 1 month we have taken care of the entire plastic surgery team has taken care of the patient, and still as Dr. Selva Sita Raman's patients, only after the hand transplant that patient also undergone the marriage and is okay now. Because that time we had a lot of doubts about the hand transplant, how this immunological that is immunosuppression is going to affect the patient. But now our dean also is insisting we have to do the hand transplant. We will get ready, because for the workup also we have to do the base work. We will do that. We will do in MMC also. We will organize nicely the team, and we will do the hand transplant in MMC also, because that also we will take care. Thank you.
So Dr. Selva, I think that was a beautiful presentation and you made me cry. I don't think nobody else in MMC has made me cry. You made me cry. So one thing which I learned was you always, you go first, is it, even before the gastroenterologist, at the time of the retrieval, the hand is retrieved first, is it? That is how what I...
Yeah, it can be simultaneously or it should not be a problem. It can be done simultaneously.
Simultaneously, yes. You did not take much time either.
It is exactly 15 minutes for both the hands.
Okay. Right. And another thing is the prosthesis. You will be bringing it at the time when you come.
We bring it along with the patient. Wherever we go to harvest, we take it along with us.
Okay.
And we remove the once the patient is declared at that, because once we remove the tourniquet, the patient will get problem. So we leave one of our colleague there.
Okay.
Once the thing is over, entire harvest is over, other organ, then we remove the tourniquet and suture this.
Okay. Because I'm asking you this because it will be easier for me to, or for the maintenance team to talk to the patient donor family, because they will, as you said, rightly said, they will be very apprehensive about it. And I think for every person who maintains a donor, every time the hours are long, we do a lot of hard work, but at the end of it all, when we see the organ being used well and being shown to the donor family, I think it completes the cycle, and I think that is what made me very emotional. And I think you're a very good human being. Apart from your clinical surgical skills, I think you are a beautiful human being. May God bless you abundantly with lots of good health and happiness, because you are going to do tremendous work. I can see it through your presentation, the way you spoke, your emotions. I think the generation of today, they study a lot, they do a lot, but this emotional, networking seems a little bit lacking, and you, God bless you, you have abundant. God bless you abundantly. And NGK sir, a full 100 marks to you. Thank you.
Here the value of tax level which you make is for the first 3 months is more than, it's around 12 to 15. It's very high, and we try to make the next, after 6 months we maintain minimum of 8 to 10. And skin is one of the most immunological tissue. I think the liver and other organ, they are all single tissue. Hand is a composite, so we call it VCA, vascularized composite allograph. It has bone, tendon, muscle, nerve, blood vessel, and skin. Skin is one of, we have the presence of the Langerhans cells. It's one of the most immunological organ. So it initiates the immunogenicity very high. So we need a high amount of immunosuppression to maintain a normal life, and they should not get a rejection. That is one. At the same time, one good point is most of the patients which we operate here is around 20 to 30 years, and they have no comorbids, and all other organs are functioning very well. So they will be able to take this immunosuppressions very well. I think, but if you say kidney or liver trauma, they will already have a lot of comorbids. Most of the people, more than 90%, we say they have diabetes, hypertension, and they have some problems in all other organs also. So these people are also able to maintain them very well.
So simultaneously the bone and tendon and every repair will be going on simultaneously.
Yes sir, yes sir.
So there is a space for all the surgeons to operate simultaneously.
Yeah, so no, first thing, for anything in the foundation is a bone fixation, sir. First, the orthopedicians start, so usually when we start, it will be 4 teams will be working simultaneously. So the moment we harvest the organ, wherever we are, suppose we are harvesting, for example, the last cadaver hand came from Erode. The moment they started harvesting around 5 o'clock. The same time we, wheeled in the recipient. So we started the dissection because we have to dissect and label each structures separately. So that bilaterally it has started. The moment the hand arrived, again 2 teams will be shifting there and they start the working, dissecting all the organ. Once we finish the hand, then the size, the length match should be done. Then we cut the extra bone. Then we give it to the orthopedician. They use the plates and screws to fix it. Once they fix it, then we first thing, depending if the time is very short, we first start the anastomosis, finish the anastomosis. Then we start the muscles, nerve one by one we'll start doing. But first thing is bone fixation, then they move out, then the plastic surgeons come in again.
How do you match the color?
Yeah, there are two things, ma'am. One, we generally don't look for color much too seriously. One. Second thing is, when a patient, whatever patient's color we are getting in, because of the patient's hormone, for example, the last patient which we did was a female to a male. So she is a fair. But when we when the masculine hormones act, it naturally the skin gets virilization. It becomes little, skin also becomes little masculine. One. And same, whenever patients are taking on immunosuppression medication, they usually have a little bit of lighter tinge of the skin. So most of, initially the difference is quite gross, but when they, after 6 months to 1 year, the difference comes much lesser. Yeah, girth usually, see, when we join at that point, we usually overlap the muscles and the skin. So there will be bulge. But that contour correction again comes, it becomes better in 6 months to 1 year, or if needed can always be corrected. We did correction for the 2 patients, ma'am. We did correction. Because the patient complained the bulge is little more, then we used to do a correction.
So diagnosis of rejection is only clinical or histopathological?
See, the protocol biopsies can be done. Usually what they do is, initially when they started in India, they started 1 week, 2 weeks, monthly intervals. So most of us, what we follow is done by Amrita. Usually we discuss, and now the global team has done the maximum number. So initially we discussed Amrita. So what they did is they did a protocol biopsies 1 week, 2 weeks, 1 month, and every month, then 3 months again. But they didn't correlate with the findings, the patient when they are going to get a rejection. So now they are told, if you only have a slightest doubt at that time, take a biopsy and send. Biopsy report will come within 24 to 48 hours. So basically, if you have a doubt, you can take a biopsy, start a pulse steroid. If it seems to be cellular, start a pulse steroid and then send a biopsy. For 24 hours, the result will come. Then we can plan accordingly. And that's why it's one of the easiest to detect. The moment you see the rash. But in other organs, there are hidden organs. They have to even take a biopsy or the urine output. The patient usually come late. Yes, they come early, and we also teach them how to detect something different. Thank you so much. Thank you so much for the opportunity once again. Thank you, sir.